Hi, good afternoon, everybody. Welcome to our webinar on common health disease myths. Without further ado, I will hand the time back to Dr. Jeremy Chow. Doctor, thank you.
Thank you, Robin. Good afternoon, everyone. My name is Dr. Jeremy. I'm a cardiologist, and I come from a group practice called Asian Heart and Vascular Centre. So I hope everyone can hear me quite clearly. The abbreviation for our group is AHVC. Maybe just a little bit about my team. So I think we are the biggest cardiology team in private practice. We are a team because we are all associated together as a group practice with AHVC. I'm using my cursor to show you the different members of my team. So this is the medical director, Dr. Chuang. He's a heart failure specialist. This is Dr. Stanley. He's an interventional cardiologist. I always call him the plumber because if you have blocked arteries, you go to a plumber. Just like if you have a blocked water pipe, you go to a plumber. This other handsome tall guy is Dr. Tan Chong Hyok. He's also an interventional cardiologist, another plumber. So we have two plumbers. I am the electrician. I'm the electrophysiologist. It's a very big word, but what it just means is that if you have got a heart rhythm problem, you have got irregular heartbeat, too slow, too fast, palpitations, then probably you may have to see me or someone like me to sort out the electrical problem. Dr. Agate is an interventional cardiologist who's going to join us, supposed to have joined us this year, but because of COVID, we are delaying we're delaying him coming out from NUH, so he's going to come out end of the year. He also does a very interesting niche work where we can do minimally invasive procedure to repair heart valve or repair or replace heart valve or close certain holes in the heart. So he's the subspecialist in it. And very fortunately, we have two ladies in our team. So I think we are the only team that has got two ladies, Dr. Goh Ping Ping and Dr. Chan Wan Xian. They are both ambassador for the Singapore Heart Foundation, Go Red for Women, both doing echocardiology imaging, and Dr. Chan also does heart failure. So we have a very complete team of specialists who most of the time, I would say 99% of all heart conditions should be manageable in our team. So I think if for the majority of people who are used to the public care service, so if you go to a National Heart Center, for example, you will find the same type of specialists, but of course a bigger number in National Heart Center, but we do have the full complement in Asian Heart and Vascular Centre. And we are actually located in three of the Parkway hospitals, so Mount Elizabeth Orchard, Mount Elizabeth Novena, as well as Glen Eagles Hospital. We are there different people will be there on different days. So we all have a more or less a schedule. So if you need to make appointments, you can just call up the clinic, which I'll give you the website. The website is ahvc.com.sg, and you can get more information from the website. Okay, so the last part of the marketing would be to also share with you what we do. So because we have the whole complement, the list is pretty long, but it's not fully exhaustive here. But in general, we do all the preventive screening and general cardiology consultation. We do interventional cardiology work. We do heart valve surveillance work. We manage complicated heart failure or advanced heart failure patients. I do all the electrical related work. That means anything to do with short circuit, heartbeat too slow, put in pacemakers. That is my specialty. We also do structural heart disease work. And lately, we are also interested in doing these two very small niche, but very important in developing fields called sports cardiology, meaning people who wants to do sports. Let's say you want to do your first marathon. Well, should you do it? Are you fit to do it? Is there anything you need to worry about? Maybe we can help to address that concern before you embark on your training and go for that 42 kilometers run. And this very, very big field that is now developing, which is cardio-oncology. These are mainly for all our cancer patients who have survived, who have gone into survivorship, who have been cured of their cancer, because it's either a very early disease or the advanced technology have allowed them to go into a remission, then they are considered cured. Cure is always relative in cancer, but if you have no disease for 5 years, you are really considered to be in very good position. But unfortunately, that is also when certain things related to the heart due to the previous cancer treatment may emerge. And therefore, this is a very big field that is now under great interest and development. Okay, before I start my talk, I thought maybe we'll just show you some statistics. So this is the 2016 WHO global cause of death. And if you look at this in terms of millions of people dying from diseases, heart diseases is usually number one. If you add heart diseases together with stroke, because they are the same underlying problem, means blood vessels getting blockages, for example, or bleeding, for example, these are all conditions that coexist between heart patients and patients with stroke. They account for a lot of deaths as compared to infections, lung problem, or even cancer. So cancer on the whole has improved in terms of death rates have gone down drastically. So cancer today is almost like a chronic disease, if I may say. That means you can treat it, you can control it, it can be managed. You may not be totally cured, just like if you have diabetes, you may not be totally cured, but you may have very, very normal life, good quality of life, as long as you get the right treatment and effective treatment. Okay, since it's COVID, I guess we can't run away from COVID, right? So we are all worried about death rates in COVID. We are all being in our circuit breaker. That's basically another electrical word that came from our minister who has an engineering background, right? The rest of the world calls it a lockdown, but in Singapore, we call it a circuit breaker, right? So one of my patients asked me, what exactly is a circuit breaker? I said, that's the thing in your room, in your house, which controls all your electrical supply. So when you have a trip, you have to go to that circuit breaker to push a button so that all your electricity is restored. So that is a circuit breaker, right? But ours is an extended circuit breaker in this COVID period because, you know, it's like 2 months. You can't do quite a lot of things, but it's for the common good. Why? Because we are worried about death rates. The main concern during COVID is when there is an increase in number of patients falling sick suddenly, no matter how good your healthcare system is, the infrastructure will always be stressed and strained, and you may not be able to manage all the sick patients at one time. All right, that's why we have to take certain measures. That's why we are all doing this webinar instead of meeting face-to-face to do a talk, you know. Because death rates, unfortunately, in some countries, I think this is not the most updated. If you look at today, Brazil is up there because we have also a lot more deaths in Brazil, Europe, and in the US. So in comparison to heart diseases, well, these are pretty small numbers. But of course, we can just argue that this is just the last 3 months, 4 months compared to 1 year or 2 years of data that you consistently see for heart disease. So heart disease is a chronic disease. It affects a lot of people, and unfortunately, it can cause a lot of mortality. Infection will cause a lot of acute deaths, but overall may not affect that big a number of people, depending on how what kind of precautions we take, right? Okay, to start the ball rolling, let's understand how the heart works or what the heart looks like. All right, so the heart is actually a muscular pump. It is connected by blood vessel. There's blood vessel returning blood, and there's blood vessels leaving the heart. So in essence, it's just a pump. But I think it's very useful. Whenever I give talks to the public, this is the easiest way to let everyone understand. You can actually break down the heart into 3 separate compartments. And one of the compartments, you can liken that to a 4-room flat or 4-room apartment. You have got rooms, so the heart has got rooms. You have got doors between the rooms. The heart has got heart valve, which are like doors between the rooms to allow the blood to flow in one direction. And there's always an inlet and an outlet. So there's a right side of the heart and there's a left side of the heart. So the heart is a 4-chamber muscular pump. But just like your house, you need to be connected by water pipes and sewages. So you have clean water coming in, and then you have dirty water leaving your house so they don't get flooded. So this piping system is also present in the heart because the heart is a muscular pump. It has to work non-stop. As we are talking, as we are sleeping, it is pumping regardless of what you're doing. And that it can only be done if it has a constant supply of energy coming through the blood supply, as well as getting nutrition from glucose, for example. So this is your water pipes in your heart. And the last part, which is my specialty and special interest, would be, you have a circuit breaker at home in your house, so you have electrical wiring, without which you can't do a lot of things. You can't even go onto this webinar if you're not connected to the internet or by electricity. So the electrical component of the heart is another separate entity. And this component of the heart sometimes can be a little bit more difficult to understand because there's a lot of different circuitries, and different parts of the circuitries can give rise to different conditions. So just giving you these three simple analogy, I think you probably can understand that in today's context, in 2020, it is probably not possible for one cardiologist to manage all the different things because they're all very subspecialized. So you may be able to understand all the conditions and manage them, but you may not be able to be a subspecialist to tackle every single intricate details. That's why in AHVC, we believe in teamwork, or so-called team management. All right, so this is the circuit breaker. In case you don't remember what it looks like, there's one somewhere in a corner of your house. Okay, so today I'm going to briefly go through some very, very common things that my patient will tell me in my consultation room, right? So the first one, which is the most common, they'll lead everyone to go and see a cardiologist, is that I worry that this chest pain is going to be a heart attack. Is this a heart attack? Am I getting a heart attack? I think I'm going to use some pictures to illustrate when you need to worry it's heart attack, what are the other common causes. But the next few questions are very common, doc, my blood pressure is okay, if you want to speak in Singlish, they say, doc, my blood pressure is okay lah, I don't want to take medicine. Can I don't take medicine? Can I just do something else? Or doc, no, I know my cholesterol is a bit borderline, everyone says their cholesterol is borderline, maybe I don't take medicine, why don't I just control my diet, right? Or worse still, doc, now my cholesterol is very good, after you give me the medicine, can I stop it? So I think you must understand why certain things are done so that you can appreciate why certain things may not be able to be stopped. The last two will be very common scenarios that occur. It could be in you, it could be in your family members, your parents, or your senior family members. Someone has gone through angioplasty, which is otherwise known as ballooning and stenting. They will think that invariably my heart condition is cured and I'm good, right? Or I've gone for my bypass 15 years ago, I had a bypass and I'm still very healthy, very fit, I can still run. I shouldn't worry anymore because I had a bypass. So some of these, unfortunately, are not the gospel truth. There are certain things that we will need to highlight to the audience today that maybe you need to still do some checks and balances here and there. Okay, first one, am I having a heart attack? Doc, I've got chest pain, the pain is in the center of the chest. It has to be the heart, right? It cannot be anything else. Well, fortunately, it is not so straightforward. There are many things in the center of the chest. The heart is one of them. The lungs are here. Below is the stomach. So anyone who has got a gastric problem with symptoms that can be suggestive of heart attack could also be just having a simple acid reflux. Otherwise, layman's term is a heartburn. It could be just muscle pain on the chest wall, nothing to do with the heart. So these are the things that are more common. Of course, if it's related to the heart, then it can be due to the blockage of the arteries that I showed before. The pipes gets blocked. It can be due to a heart valve problem. Maybe the doors of the heart valve, the heart is not working very well and causes some situation. So there are more than one causes for chest pain. The most common one, probably depending on the age group, may not be a heart-related condition. But certainly we want to make sure and exclude it is not a heart-related condition. So what are the common symptoms and signs of a heart attack? Well, you don't just get pain alone. They usually come with some associated symptoms, including, for example, pain going up to the jaw, you have back pain, or pain in the shoulder and the arm, classically the left side, not the right side. And you usually may experience episodes of difficulty taking your breath. It's not like you need to take deep breath, but you can't catch your breath. And some patients may even have very bad nausea, vomiting, and lightheadedness. These are more typical of heart attack. And if your chest pain comes with a combination of this, then you should quickly see a doctor, preferably call the ambulance and bring you to the nearest hospital to seek medical advice and attention instead of waiting and waiting and waiting. Right? But if you don't have any of these constitutional symptoms or associated symptoms, maybe your symptom is not typical of a heart attack. However, a lot of things in life is complicated by gender. So whether you are male or whether you are female, the symptoms may be similar, but from the cardiologist perspective, at least from our experience, we know that a lot of males will present with the typical symptoms of the previous slide, which I showed you, which is this one. A lot of females, unfortunately, will have some variation of those symptoms. So you will still get a bit of nausea. You may still get a bit of pain going up the jaw to the shoulder, but not always or not often you might feel a distinct crushing chest pain. So the chest pain will feel like someone's sitting on you, or the pressure is in the center of the chest. It is not those pinching pain or pulling pain, right? And the pain sometimes is not associated with breathlessness in lady, but sometimes a lot of them complain that they're very, very tired. Okay, so very, very tired alone is not a symptom of heart attack, but if you have chest discomfort and you're very, very tired, maybe you should get some checks done to ascertain that you're not having a heart attack. That's for the ladies, okay? Okay, so with those few myths clarified, so now you can understand what is the chest pain that you need to worry about. I'll go back into the risk factors, which I'm more interested in sharing. So first thing first, I'll talk about blood pressure. A lot of people know that blood pressure is a set of numbers. The machine will show you the numbers. There's a top number, there's a bottom number. So what does this two number means? Well, this is a systolic blood pressure. What it means is how forceful the heart pumps. So if you look at my hand and it's like a heart, it pumps, it squeezes. How hard the heart squeeze, it gives you the top number, all right? How good the heart relax before the next squeeze gives you the bottom number. So there is the systolic and there's a relaxation phase, okay? What is high blood pressure? Well, this again was very controversial in 2018, 2019. The American College of Cardiology's guidelines have shifted a little bit. They brought the bar down. So anyone who has a blood pressure of above 130/90 is considered to have hypertension, okay? What is really, really normal is if your blood pressure is consistently below 120/80. But unfortunately, in Singapore, Ministry of Health, after the discussion, they decided that they will still stick to the conventional 140/90 as the cutoff to recommend medical treatment. And they advise all medical practitioners to look after patients and advise them appropriately if their blood pressure hangs around 135, 134, 82, 89. And our normal in Singapore is about 10 millimeter mercury higher. So it's 130/80 and below is considered normal, all right? I guess there's no right or wrong. Depends on how strict you want to be, how safe you want to be. So if you look at the traffic light, I mean, green light is always good. I think everyone agrees that 120/80 is green light. So green light, stay in the green zone, that's good. Once you veer towards the yellow zone, move back to the green zone, get to the green light. This is quite similar to your DORSCON. So technically today we are DORSCON red, but we are not red yet because no one says it's red. So we are medically, we always joke among ourselves, we are bloody orange. We are still not red. But we are doing everything we are doing in red. So I think if we are veering towards a higher number, regardless of what you want to take the cut off as, it is always good to try and get back down to the green side, which is 120/80. Okay. So numbers are numbers, but if you ask me, I will take 130/80 as a cutoff, above which I will recommend certain things to be done for those individuals. And this is based on statistics. So if you have a pretty good blood pressure, 120/80 below, which I showed you just now on the green traffic light, your risk for cardiac mortality or dying from heart disease is 1 times. You take that as your marker, right? Once it goes up to 135/85, and if you remember what I just said, Singapore 135/85 is not hypertensive, 140/90 is a cutoff, but the risk of having a heart-related complication is already 2 times. If you are 155/95, your risk is 4 times. Okay, so needless to say, forget about the above 180/100, right? Your risk is 8 times. So this is all in comparison to 115/75, right? So I think first take home is that, high blood pressure is something that we need to be really careful about. It's very common. It is associated with 4 common heart conditions: heart disease, which is artery blockages; stroke, diseases in the arteries of the legs, for example, you get peripheral artery disease, poor blood flow down to the legs, and lastly, heart failure, right? So heart hypertension has got a very high risk for all these conditions. So in a person who has high blood pressure in the blue bar, the risk is always higher than a person who is in the yellow bar, which does not have hypertension. And this is gender regardless of which gender you are in. So the risk is almost 2 times up to 4 times higher for different conditions for different gender. Okay, first myth. This is very common. Every single patient above 75 years old will tell me, doc, everyone is getting older. It's natural part of aging. So higher blood pressure is quite normal in the old age group. But unfortunately, this is a myth. This is not true. Otherwise, every single elderly who is 80 years old should have hypertension. But this is not the case. And I'm very sure you will be aware this is not the case, because if you have family members in your family that's 80 years old, not every one of them needs to take a high blood pressure medication, right? And this is verified by all the data. So regardless of whether you're below 60, 60 to 70, 70 to 80, or even the orange triangle above 80 years old, there is a standard variation of normal. And in order for the risk to be neutral, 1, that means no risk or low risk, the average blood pressure is still hovering between 130 to 140, this line, systolic, and diastolic, the number is still very much to be desired between 60 to 80. So this is called the J curve. If the older you are, the higher your blood pressure should be, then we should see this curve shift towards the right side, which is not true in all population studies. Right, so that's number 1. It's not true that the older you are, the higher your pressure should be. Okay, but this is true. You come to my clinic, you see me, and you are very anxious, your blood pressure shoots to the roof, and then you just say, doc, this is not my usual self. I'm always okay at home. It's only when I see you that your pressure is high. I would accept it if it's a once off or 2 times in a row, but if every single visit is high, then it's going to raise the question, is it really just anxiety, or are we not facing the truth, right? So multiple readings that are high, especially if you check your blood pressure at home, cannot be due to stress, all right, or otherwise known as white coat hypertension, right? So white coat hypertension came from the good old days where doctors, instead of wearing gray scrubs like me, wear white color coat, and then you see the white color coat, you faint, you just have high blood pressure from it, right? So that's why it's called white coat hypertension. Usually when patients come to me like that, I will say, okay, check your blood pressure at home. If you have a machine, it'll be useful to know what your blood pressure is. It should not be above 130/80 at home. And then of course you don't check it after lunch or dinner, you check it before food, and usually twice a day at most. But more than 3/4 of those numbers must be below 130/80. So for any individual who always measure a blood pressure, it's always 132/85, 137/82, 135/84, then it's very unlikely this person's blood pressure is totally normal. So how else can we check the blood pressure if you have no machine at home? Well, in that case, then you will be fixed up on a portable machine, which we will put up from the clinic, and you go home and wear it for 24 hours. It will continuously take readings on its own. It's automated, so it's an ambulatory blood pressure machine. It will take all the readings and then do some weighted averaging, including when you're asleep, to give us a set of numbers. And the set of numbers is used and defined clinically for making a diagnosis of hypertension. So this, I wouldn't say this is the absolute gold standard, but this is the most recommended way to diagnose hypertension if you don't have the machine at home to track your own numbers. Okay, very common, patients come back after a short course of medication and their blood pressure is perfect, their headache is gone. Some of them usually have headache and dizziness when they have high blood pressure, but if everything is gone, they say, doc, I'm okay, I'm feeling good. Can I cut my medication? Can I stop it? Well, my answer to them will be, no, it is always good that you are improving from the medication and you don't have side effects from the medication. So now your pressure is good. Then you now need to understand why we are controlling blood pressure. We are not here to just make the numbers look good. That's not the objective. The objective is to reduce your risk of getting complications. And complications can be as small things as bleeding within the eyes, which will cost you your vision, all because of blood pressure problems, to one of the most scary thing that you will see on TV, getting all these lines hooked up. This is a patient on dialysis, so you have kidney damage, you end up with dialysis. Is something even more painful to go through than taking 1 or 2 pills a day. And lastly, if you get a stroke, either because the pressure is too high and the blood vessel bursts, or it forms a blood clot and causes a blockage, both of which would be something that is unlikely to be reversible. And if this thing happens to any healthy 50, 40 years old, the rest of the life is going to be a bit challenging because you may be quite incapacitated. So if you understand we are controlling blood pressure, not because we just want the numbers to look good or not because we just want the headache to go away, and you can appreciate that we are trying to prevent end organ damage from stroke, kidney failure, as well as even simple things like blindness, I think then you can appreciate why we should not stop medication, all right? I'm not even going to go to heart attacks because I think these three are bad enough for anyone to have without having a heart attack, all right? So I'm going to switch gear a bit and go on to cholesterol. Unfortunately for doctors, it's always difficult when we come to face a patient who will bring us one of these books which are written by doctors who says that, all this cholesterol thing is a myth, is a hoax, it's just pharmaceutical companies trying to sell drugs to make money and then make patients take medicine for nothing. Because the truth is, a lot of patients who are on cholesterol pills will not feel a difference whether they take or they don't take the medication. In fact, a majority of them who have side effects to the medication, if they do have it, they will feel worse taking the medicine than not taking the medicine, right? That's almost always the reason why you see bad press on the internet on cholesterol medication. But well, do we really need cholesterol? Answer is yes, we need cholesterol. Without cholesterol, we can't make our vitamin Ds. We can't make our sex hormones, our testosterone, estrogen cannot be manufactured by the body. We cannot make stress hormones. So when someone takes a knife and sticks at your throat, you won't have the ability to run away or defend yourself because these are all stress-related reactions. All right. You also need it to make this greenish pigment or these yellowish pigments that will help you to digest fats. And this is bile acid. So you need cholesterol. And more importantly, you also need it as an antioxidant to protect all the nerve function. So it is something that we need. But a lot of times we have too much of it. That's the problem. It's not that we don't need cholesterol, but we just have too much of it. And if you look at cholesterol recommendation, this is just a medical graph showing the higher the cholesterol number, whether you take the US number, which is by milligram per deciliter, so it goes in the hundreds of 100, 130, 150, or you take the standard international index, which is the units are in millimoles per liter, so the numbers from different GPs will come out differently. So 110 is equivalent to about 2.8, for example, and this is the LDL bad cholesterol. It is uniformly accepted that the lower, the better. But of course, how low is low and how good is good? Well, if you take a baby's cholesterol is somewhere around here, about 50. So when you're born as a baby, and just remember, maybe most of us won't remember, but for those who are parents here, you always feed the baby nothing but milk in the first 5-6 months before you start weaning them, right? So the baby only drinks milk. There's no way you can get a lot of cholesterol from milk. You can get fats from milk, but you don't get cholesterol from milk, especially not from breast milk. Formula milk, a lot more fats, but again, you don't get cholesterol. So the cholesterol that you see in babies are the cholesterol that the body makes, and these are the cholesterol that the body needs. And therefore, we come up with this so-called magic number of 50 or 1.3. And that is perhaps what the low should be if you want to be healthy, because most babies are born healthy, right? We only start becoming unhealthy after 6 months of life when we start putting food into our mouth besides milk. So that's why things changes as we start to eat and start to have teeth. So that's the main problem that I think most of us are facing. Okay, my GP always says my cholesterol is good and I don't need medicine. And every time when the patient tells me this, I will always ask them, so what is your cholesterol number? I can tell you 9 out of 10 patients won't be able to give me any number. They just say, I did my check last year and my GP said it's good. So I think number one, I hope at least the audience today after today's session will be a little bit more interested in the number, to remember that number. I mean, the number won't be a 4-digit number, so you can't buy 4D from it. But certainly it's a number that at least you should remember, because the next year when you do it, at least you can compare with the number before, right? But truly cholesterol reading could just be a number, and it's a number game, right? So if you just use a number game, in the GP setting, a primary healthcare setting, maybe there is not a lot to justify certain treatment if it's just based on number alone. So, well, I guess this is a useful picture that I borrowed from Time magazine. This is all the way back in 2005. And 2005, that's when CT scanners became more sophisticated. And we have this thing called a calcium score. So on the picture on the left, in a normal heart, the heart should look gray, 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 and nothing inside is white because there's no calcium and no cholesterol. But in the picture on your right, you can see that there are many areas of this white marker, which is almost as white as the bone. Bone is here. This is your backbone, your spinal bone. This is your chest bone. So bones are white. If you see white spots in your artery, it's usually not good news. It means that there is cholesterol deposition. And medically, we can quantify it using this score. So a calcium score would be able to identify cholesterol deposition or the process of atherosclerosis, which has already started. And usually this starts after 35, 40 years old. So there's no point doing this when you are too young. There's probably some value in doing this if your cholesterol is high, you're in the mid 45, 50 years old, and you want to know whether you need to take cholesterol medication. I never go by just the number alone. I will use this to give me an indication how aggressive I will need to bring the cholesterol down. So that is the data that this can be interpreted with. And the reason why we can use this data is because calcium score in many different medical journals, and this is one of the most reputable one for medicine, it's called NEJM, New England Journal of Medicine. If your calcium score is 0 in this orange bar, you probably will not have any events for a long time. So it's very safe, even if your cholesterol LDL is very bad. Even if LDL is 160, okay, lifestyle treatment and lifestyle modification and some advice and exercise and eat healthy might just do enough for you. But if your calcium score is 300 and you don't care about it, over time, the incremental incidence of heart-related diseases, including stroke, goes up. And this can be as short as 5 years. So if your calcium score is 0 versus your calcium score is 300, for the same cholesterol LDL, if your LDL is 100, for example, it means different things on the chart. It does mean that the person with a higher calcium score is at a higher risk, the person with a lower calcium score is at a lower risk. And for the same number, one person may need to take medication, the other person does not need. So that's how this is used to how this should be interpreted, and this should be used in clinical management. So I have moved away from just using a cholesterol number to advise people whether they should take medications or not. Okay, so $1 million question. I don't take medicine. Can I control with diet, lifestyle modification? The answer is yes, but your life will be very miserable. Why? Because if you want to live like a Singaporean and eat like a Singaporean, then it is very difficult for you to control your cholesterol, right? Because Singapore is so small and abundance with food from every single corner. Whether you turn right, turn left, go straight, walk backwards, you're going to hit food. So it's going to be difficult for every Singaporean to control. And if you really want to control very well, you really need to cut down a lot of things so that you can reduce your cholesterol by at most 35%. So what you eat, you can even extrapolate. I give you extra COVID discount, 40%, right? 40% of what you eat will get into your cholesterol bloodstream. So you'll be converted to cholesterol, you'll be absorbed as cholesterol. So in the best case scenario, if your LDL is 200 and I give you a 40% discount, your cholesterol number is still too high, right? If your LDL number is 160 and I give you a 40% discount by making you eat nothing but grass, you will live because you still have energy from grass, but you will live miserably. You will only reduce the cholesterol by 40%. So that is as much as you can do from diet alone. And if you choose to do that, then you can forget about this list of food, right? Because this list of food you'll never see it for the rest of your life, right? So things like pepper crab, char kway teow, roti john, nasi biryani, chicken satay, you can just throw it out the window. You're never going to see it again. The only thing you're going to see is green vegetable, lettuce, you're going to see grass, you're going to see celery. That's probably palatable to a lot of people, but not to everyone in the audience. Once in a while, you will eat this. But once in a while, when you eat this, it might be useful to know how much cholesterol content is inside all these things. So things that are like our good fried Indian noodles is extremely high in cholesterol because of the ingredients that they use. Char kway teow, thanks to the lard, no brainer why it's so high, right? So food, basically a lot of deep fried food, meat-based product, red meats, very high in cholesterol. But these are things you find in hawker center. Most like to eat eat this, and most of us want to eat this more than once a week. And if you still want to eat this and you want to get the cholesterol numbers perfect, then you must be either blessed with super good genes, or you may have to be on medications in order for all these things to be kept in balance, right? So how can we eat better? Well, a lot of people have this misconception that, oh, if I just don't take prawns, don't take crabs, don't take beef, don't take mutton, I'll be fine, right? I can take everything else. I eat all my dessert, I eat all my tiramisu cake, I have my Haagen-Dazs ice cream every other day. But unfortunately, all these sweet and refined carbohydrates are not great either, because a lot of them are going to be converted to fats for storage, and after a while, the fats will be contributing to cholesterol production. So even if you don't consume cholesterol by the chunks and you eat all these other food, you will give your body, which is the liver, the factory, the raw materials to make the cholesterol, and it will overproduce cholesterol, all right? If you want to eat fats, there's this category of healthy fats we'll come to next. We should always remember that you only need to consume enough for yourself. You don't need to consume excess to keep it in the storeroom. So that's the concept that I always share my patients, right? And lastly, don't forget to take more fibers, because fibers actually are bulk. They will make you feel full so that you don't feel like you're hungry and need to snack again. So what are good fats? Well, the only good fats here, which I will highlight, is in this green bar, and this is from the American Heart Association. Things that are, for example, avocado, your tuna and salmon, fatty fish, the nuts and seeds, they're generally all very good saturated, monounsaturated and polysaturated fats. And oil. So oil, what kind of oil is good? Well, basically olive oil, peanut oil, these are all okay. Sesame seed oil, these are all good oil. This is another chart showing the same thing. So for monounsaturated fats, olive oil, peanut oil, they're all good. Avocado, or your fish, these are the good fats to take. If you need to take fats, unfortunately, these are the only good fats to take. If you want to eat your McDonald's, if you are one of those people who have queued up 45 minutes last week just to get the McDonald's fix because you hadn't eaten it for the last 1 month, then those unfortunately are the very high trans fat food, which is not the best or the most healthy. But if you're going to eat it once a year, then I would have too much comments. Okay, so cholesterol medication, once started, yes, is lifelong. It is not something that we can stop, because this process can never be stopped, neither can we reverse it. So this process is called atherosclerosis, or cholesterol plaque buildup. It starts with a bit of inflammation, and then cholesterol, being the sealant that heals the inflammation, will get deposited. And the higher your cholesterol, the more aggressive the deposition goes. And if the deposition goes in this direction, it never goes backwards. So no matter what we do with cholesterol medication, what we can only do is to slow down the rate of deposition, but not reverse the process. So if you can appreciate this cartoon, then you can understand that if things only goes in this direction and not this direction, it's unlikely at any point in our life we can stop cholesterol medication once your calcium score is elevated. Okay, I think I have about 10 minutes left. I'm quickly going to touch on 2 medical treatments which are very common today for heart conditions. And the heart conditions I'm going to focus on is heart artery blockages, otherwise known as coronary artery disease, or when it happens suddenly, it's called a heart attack, right? So this is a cartoon, the description of what ballooning and stenting is all about, right? So if you have got narrowing or blockage, we put something in through the wrist or through the groin arteries, minimally invasively. We use a balloon, stretch it open. Once we create a nice path, we'll put in a stent and then use the stent to keep the area open. So this is ballooning and stenting. One question that everyone's asked will be asking, and I'll tell you right now, so you don't need to ask me, is that no, we do not get rid of all the cholesterol that has been deposited, because we can't, because they are not deposited on the surface, they are deposited within the blood vessels like this. So in order for us to treat this condition, what we can only do is to restore the luminal flow. That means try to restore the blockage to increase and improve the blood flow. And you are definitely not cured from artery disease after angioplasty. The condition has only been treated or has only been stabilized. So this is a patient, for example, 55-year-old man, he came in for heart attack. There's supposed to be a blood flow coming down. This is an angiogram. So this is the tube. This is the dye that we inject. Then we can see the blood flow, and then it stops here. All right. So the next picture is when we did the ballooning and stenting to re-establish the blood flow coming down here. So the difference between this picture and the picture before is that this artery was missing. That's why it's called a heart attack. There's a total blockage. And once we relieve the blockage, start sucking out the blood clot, we can put a stent to re-establish the blood flow. So this same patient has been seeing me for 3 years, this Indonesian patient. And 3 years later, he came back in again for gastric pain. So sometimes stomach pain or gastric pain may sound like a heart pain, especially in a heart patient. We always have to bring him in to do some checks. So he decided to come in to do a check again. And this time now we can check his arteries. It's still very good. After 3 years, the stenting, everything is perfect. There's no blockage. But this was his artery on the right side 3 years ago in 2013. And you can see some narrowing, which is not so bad at that point in time. This is a normal caliber, this is the right artery, right? But now this narrowing has progressed, okay? So that's why I say, even if you have a stent put in, it doesn't mean your condition is cured, because some things, some of this process can restart in another part of another artery. For example, in this patient, the right artery got worse, and he had to come in for another episode of angioplasty and stenting to fix this. Okay, so in cardiology, we are not plastic surgeons. We don't go in and fix every single blockage that doesn't look nice. So this is not for aesthetics. This is for functional improvement, right? So if the patient has got a narrowing that wasn't bad enough to do stenting in 2013, there is no reason to put a stent there, because complications can occur and you can't justify it. Whereas if there is worsening and there is reasons to put in a stent for treatment, that's when we'll do the stenting. So some patients will say, why don't you just fix all at one shot? Unfortunately, that's not good medical practice. So this is what stents look like before and after it's being expanded. This is the tip of a finger. So they're all generally quite small stents. There are newer technologies coming through. Nowadays, we have stents that can degrade, or what we call biodegradable, or can dissolve in the body and leaving no physical structures or foreign body behind. Okay, lastly, I think a lot of patients may have gone for bypass before 10, 15, 20 years ago, and they're feeling very good and very healthy and very well. So what exactly is a bypass? In about 20 years ago, when an angioplasty and stenting is not so prevalent and also not so advanced, a lot of blockages are not possible to be treated by putting in balloons and stents, because the technology then was too rudimentary or very basic. So instead, they had to go for open heart surgery, where the surgeons will connect all these conduits, right, to bypass the blocked vessel. So if you imagine this is our expressway and it's full of cars after a traffic jam, this is a blocked artery. So in order for you to get out of this part of the journey and proceed with your journey, you may have to find a little small lane to filter out and then go past it. So that's how bypass came about. So when you have a blockage here, and the blood cannot go through, then logically, if I connect another tube from your vein grafts down from the main artery down to your distal segment, bypassing the blocked artery, traffic flow resumes. So this is what a bypass is, okay? But if you can understand this, then you will appreciate that a bypass does not treat the initial blockage. It merely just go around it, okay? And that gives rise to a second problem. So this is what a CT scan of a bypass artery will look like. So you have a bypass graph showing very nice and still patent arteries. But unfortunately, nature has it that, certain things that are not meant to be there won't last a lifetime. So if you take a piece of graft or vein tissue from your leg and put it to your heart, that vein is unlikely to be able to withstand the stress of the heart pump and the blood flow for your entire life. And therefore, there is a life expectancy of all these grafts. And if it's a vein graft, that means those taken from the thighs or from the legs, the expectancy is actually not that great. After 10 years, almost 50% of them can get blocked. So if someone in your family had a bypass 15 to 20 years ago, it is definitely one or two of those bypass will be a vein graft. And by today, 50% of them are at risk of being blocked or have already been blocked, all right? Whereas the other grafts that we use today, mostly the arterial graft, they tend to last a bit better. Their life expectancy after 10, 20 years will still be good. Almost 80% will not be blocked, right? So vein grafts are notoriously well known for being blocked. And unfortunately, some can be blocked as early as the first year, right? So even 20% of patients can get a graft blockage or graft failure at the end of the first year. Okay, so this is just a whole comprehensive list of what are things you can do to check yourself if you need to check yourself for heart-related conditions. The list is, again, not exhaustive here.
So with that, we want to thank you. Thank you, doctor, for your time once again. We really enjoyed it. Thank you.
Thank you,
See you
everyone.
guys.
Thank you. Yeah.